KSOS. Now I welcome Dr. Lekha, Senior Consultant at Giridhar Eye Hospital, for her next talk on genotype phenotype correlation in macular dystrophies.
So, thank you. And I thank KSOS for accepting this IC, and I hope slowly we will sensitize more people to take interest on this topic. So, the previous two speakers have given a good introduction. So, my aim is to give a little more clarity on the macular dystrophies, which are those subset of IRDs where predominantly you find macular abnormality, usually bilateral and symmetrical. And obviously, they will cause a problem in the central visual function. A systematic approach is important for diagnosis. Most of the time, we may not have a definite treatment now, but that does not mean that nothing can be done for these patients. And the understanding in genetics have told us that most of them are monogenic or either linked to one gene or few specific mutations. So they are actually potential candidates for gene therapy. And these are the three most common macular dystrophies, which I am going to cover in this topic. Just to touch upon the genetics, we all know that we have genetic material in the form of DNA in the nucleus of the cell. And these genes contain instructions for making the proteins, which in turn determines our cellular function. So when you have a normal gene, you have a normal protein and a normal function. But when you have a mutated gene, you either have an altered protein or no protein at all. And obviously the function is going to be different. And that is which is reflected in the phenotype that we are seeing. So this is a 12-year-old girl with defective vision since 1 year, mainly the central vision. You can see the color vision is normal, and the fundus view as well as autofluorescence shows us the typical flags of Stargardt's disease, and OCT showed foveal atrophy. Field showed a central scotoma, and full field ERG comparing to the normal, we can see all the waveforms were normal. Genetic testing confirmed a pathogenic variant in ABCA4, confirming the diagnosis of Stargardt's disease. All straightforward here. So this is a second case. He is a 45-year-old male, defective vision since 30 years, again started by the second decade. He also had defective color vision and side vision. Family history was also positive, and we can see that his both vision and color vision are markedly reduced. Much more extensive fundus changes compared to the previous patient, and again on the autofluorescence, we can see extensive hypoautofluorescent lesions, extensive EZ loss on OCT, and significant field effect. And in the ERG, we can see that the rod response is reduced, but it's the cone response that is reduced more than the rod response. And genetic testing again showed a pathogenic variant in ABCA4, but due to cone rod dystrophy. Third case is an 18-year-old male with defective vision since 1 year. He had, apart from central vision problem, night vision, color vision, side vision, everything was affected. Fundus picture almost looked like an RP with changes extending to the mid-periphery, extensive EZ loss on OCT, advanced field effect, and reduced waveforms, both cone as well as rods affected. And here also it was ABCA4 with retinitis pigmentosa as the diagnosis. So I showed you three different phenotypes. All had problem in the ABCA4. So this ABCA4 retinopathy is actually a broad umbrella term and involves heterogeneous group of conditions. So let us try to understand a little more about ABCA4. ABCA4 stands for ATP binding cassette, subfamily A, member 4 gene, and it encodes a very retina-specific transmembrane protein, which has an important role in the retinoid cycle. So retinoid cycle is what happens when the light falls into a photoreceptors. The rhodopsin is converted into all transretinal, and a series of changes happen leading to the formation of certain byproducts. And it is this ABCA4 which translocates these products from the inside of the outer segment disc to the cytoplasm. And when you have a dysfunction of the ABCA4, there will be buildup of these visual cycle byproducts, which then integrates with the lipofuscin in the RPE, leading to dysfunction of the RPE and subsequent degradation of the photoreceptors. That is how a problem with the ABCA4 leads on to the changes in RPE and photoreceptors. So with this understanding, let us try to see this. So when you have a normal ABCA4, the rods and cones are intact, waveforms are normal, and fundus is normal. When there is a partial dysfunction of ABCA4, there may not be much of visible injury to the rods and cones, so the waveforms may be normal, but you see the changes of Stargardt's disease. But when there is more severe dysfunction of ABCA4, there is definitely more damage to the photoreceptors, especially the cones, we can see there is some thinning of the RPE and more accumulation of these toxic products, the bisretinoids, which is also reflected as decrease in the waveforms on ERG, and this is what you get in cone rod dystrophy. And if the ABCA4 is totally absent, there is extensive apoptosis of both the rods and the cones, significant thinning of RPE, absent waveforms, and you get the picture of retinitis pigmentosa. So ultimately, it depends on the severity of the genotype, the sensitivity of the foveal cones to the genotype, and the sensitivity of the RPE to the genotype. So what can we do to these patients? We have heard it before, gene therapy or stem cell is still in the research level, but we can try to do something which is called as a pharmacotherapy by utilizing agents for their anti-inflammatory or antioxidant or neuroprotective effects, which can try to reduce the accumulation of these byproducts, and various agents are being investigated, of which one such agent is metformin. Because of its safety profile, affordability, we are also undertaking a trial on the role of metformin in Stargardt's patients. Supportive measures are extremely important. It has already been touched upon by Dr. Divya. And again, I would highlight that avoid any kind of supplements, especially the antioxidants, because it might do more harm than good. And this is a practice which is still continuing in many places. Just because we don't have anything to do, that does not mean that we have to give antioxidants. This is a 55-year-old lady. She said she has been having subnormal vision in one eye earlier, but little worsening last 1 year. Vision was reasonably okay. Color vision was normal. We could see yellowish deposits in the foveal area in both eyes with hyperautofluorescence on FAF and hyperreflective subretinal material on OCT. Field showed few central defects. Full field ERG was normal, but EOG showed a reduced Arden's ratio suggestive of the variant of Best dystrophy, which is the adult onset fovea vitelliform dystrophy. So if you see the phenotype of West disease, the very first stage is actually a preclinical stage where you need imaging to diagnose it. But the classical lesion is a typical ear-gluque vitelliform lesion, which can progress to pseudohypopyon, vitelliruptive, or even atrophic lesions. And the causative gene is the BEST1 gene, which is located in chromosome 13. It encodes bestrophin, which is located exclusively in the RPE, and its main function is a channel protein. This regulates the flow of chloride ions in the basolateral membrane of the RPE. So chloride is important for fluid balance and generating electric signals. So basically, it has a lot to do with the RPE pump function. So when there is a mutation in the BEST gene, there will be loss of this pump function. So RPE becomes swollen and unable to process the debris. So all the debris will build up, and that causes a physical barrier. And the deposition of lipofuscin causes more damage to the RPE and photoreceptors. And eventually, with the breakdown of blood-brain barrier, abnormal vessels can also grow, leading to the formation of CNV. And this is one indication for intervention in BEST disease. Now, this is a 7-year-old boy with defective vision detected at school. Family history was positive, but note that it is the brother and the uncles who are affected, and both parents were born of consanguineous marriage. Vision was 624, color vision also mildly affected. A careful examination, which can see could some skytic changes, but it's not so clear in this photograph. But it is very well seen on OCT, especially the wide field OCT, which showed that these changes extend much beyond than what could be seen clinically. And ERG showed the characteristic electronegative B wave, which is suggestive of juvenile X-linked retinoschisis. This is due to a defect in the RS1 gene located in the X chromosome. It is inherited in an X-linked manner. And this encodes for the protein retinoschisin present in the bipolar and photoreceptor cells. It has an important role in cell-to-cell adhesion. It is also important in signal transduction. So this explains the phenotype now. It also regulates the fluid balance and tissue osmolarity. So because it disrupts the adhesion, you get the skytic changes, the emergence of fluid-filled cyst, and the signal transduction is affected, so you get the electronegative ERG. So that's how you correlate the genotype with the phenotype. So they present with central vision loss, and by second decade, foveal schisis is seen in 100%. Rarely they can have complications like retinal detachment, vitreous hemorrhage, etc. So dorzolamide has been tried, and if they develop complications, surgery is required. There is no role for any laser, and they should be advised to avoid contact sports. So to conclude, our understanding of macular dystrophies have greatly improved. Multimodal imaging and electrophysiological test has helped us to characterize these lesions better. Genetic testing have helped us to understand the molecular basis, and because it is now more accessible and affordable, we should have a tendency to investigate them on the genetic side also. So future direction would be therapeutic strategies which can halt or slow the visual loss or even restore visual function one day later. This involves a team approach involving retina and pediatric ophthalmology specialists, because most of them will be coming to the pediatric ophthalmologist, geneticist, and a genetic counselor. Thank you.